Hello, my name is Michael. I'm currently a FY2 at St Peter's Hospital in Chertsey, and today I'm going to be talking a bit about blood tests and the liver. So today we're going to be talking about what you get when you request LFTs for a patient. We're going to be talking about the different types and patterns of liver damage and how these are reflected in LFT derangement. And we're going to look at what actual tests of liver function are versus what looked simply at damage of hepatocytes. So what do we get when we request liver function tests? Well, more often than not, you'll get ALT, ALP, bilirubin and albumin, and some centres might include AST and or GGT as standard. Now, the enzymes that form this, so the ALT, ALP, AST and GGT, are not a marker of liver function, but rather a marker of liver damage. And beyond that, they require active damage. So if damage has occurred in the past and the patient has a cirrhotic liver, but there is no current active process that is causing active necrosis of the hepatocytes, they can have normal liver enzymes. Also, they require a necroinflammatory disease process to be occurring. So this means that there is active hepatocyte necrosis with spillage of the hepatocyte content into the blood, as opposed to apoptosis, which is more programmed and does not involve the same spillage of enzymes. Apoptotic diseases are things like alcohol-related liver disease and NAFLD, and can occur with quite significant disease burden, but normal liver enzymes. So how do we interpret derangement in these enzymes? Well, do we look at the extent? Well, whilst the extent of derangement can be useful in ascertaining what the disease process is, there's very little prognostic value in it. If we look at hepatitis A, which is an acute condition and can cause very rapid increases in ALT that are quite large, in a year's time that patient will likely have completely recovered from their illness. However, we compare that to hepatitis C, which is more indolent, chronic, and has much more modest derangements in the liver enzymes. Years down the line, these patients will still have active disease and can progress to end-stage liver disease. Do we look at resolution? So do we follow the liver enzymes for weeks until they get better? Well, there's danger associated with that, because some countrywide audits have found that more than 50% of patients who end up presenting with end-stage liver disease without an underlying diagnosis of chronic liver disease have been found to have deranged LFTs in the past. And the danger is that people can see this, not investigate for an underlying chronic liver disease cause, watch them get better, which can often happen in chronic disease that waxes and wanes, and then ignore it until the patient rocks up to A&E with end-stage liver disease. The most important way to interpret these is by context, good clinical examination and good history, looking for what could be causing this deranged LFT. So we describe two main patterns of liver enzyme derangement. The first we'll talk about is hepatitic, and that's a predominant rise in ALT and AST, which represents a more liver parenchymal disease process. ALT and AST are present in hepatocytes, but also many different tissues in the body. So a rise can reflect disease processes happening elsewhere. However, this is more the case for AST, and ALT is considered the more liver-specific enzyme and is therefore included more routinely in the LFT panel. However, AST might be more sensitive for liver disease. The ALT to AST ratio is important. It's normally greater than 1, so ALT is normally higher than AST. However, this is reversed in alcoholic liver disease and also in late cirrhosis. And this holds true for even if both values are in normal range. If AST is higher than ALT, the patient may have severe cirrhosis underlying. A specific example of hepatitic pattern is massive transaminitis. Transaminitis refers to a rise in the transaminases, so ALT and AST, and massive transaminitis generally refers to values of greater than 800. This narrows down our differential to these four main things: ischemic hepatitis, where there's reduced blood flow to the liver, either due to systemic shock or a local pathology; toxins, in particular paracetamol, and notably this doesn't mean alcohol. Alcohol hepatitis rarely has an ALT of greater than 500. Biliary obstruction can also cause these massive derangements and acute viral hepatitis. As we get to values kind of above 1,500, ischemic hepatitis and paracetamol overdose become the major differentials. And the higher you get, the more likely it's ischemic cause. The other pattern we're going to talk about is the cholestatic pattern, which represents a predominant increase in ALP and GGT. These two enzymes are on the canalicular membrane of hepatocytes and so are more sensitive to biliary pathology. ALP is also present in placenta and bone and so can be raised in bone diseases and also physiologically in pregnancy. Now, these are different isoenzymes and you can use an assay to distinguish them, but it's much easier to just use GGT because GGT is not expressed in bone. So a rise in ALP and GGT suggests a biliary pathology. GGT is also interesting, particularly in looking at alcoholic-related liver disease. It seems to be increased earlier than the other enzymes and is also not increased by social drinking, but by drinking at levels that could be harmful to the liver. Now, these enzymes look at liver damage, as we've discussed, but what looks at liver function? Now, looking at synthetic function, we can look at clotting, so INR in particular, albumin, which, as we've said, is part of most LFTs, platelets, glucose, insulin-like growth factor 1, and cholesterol. As we've discussed, the enzyme part of the LFTs reflects active hepatocyte necrosis. Necrosis also results in release of other things that are in high concentration in hepatocytes, such as ferritin, vitamin B12, alpha-1 antitrypsin, and bilirubin. But bilirubin can also reflect the metabolic function of the liver, and we'll discuss how. Globulin as well is another thing that can represent metabolism in hepatocytes. So clotting is actually a very useful test for looking at the actual synthetic function of the liver, because the liver produces many of the factors involved in the clotting cascade. However, we only really see a deranged INR if more than 70% of synthetic function has been lost, so you need quite a lot of liver damage. It's also worth noting that a raised INR can be caused by other processes going on, in particular vitamin K deficiency. A lot of cirrhotic patients are quite malnourished and due to biliary problems have problems with fat processing in the gut and resultant vitamin K malabsorption. So what we can do is make sure these patients are vitamin K replete by giving them vitamin K and then rechecking INR, and whatever's left is likely to be reflective of liver disease. However, raised INR doesn't necessarily mean that these patients are more likely to bleed. Whilst, yes, there are loss of these procoagulant factors, we also have loss of anticoagulant factors such as protein C, and cirrhosis is associated with widespread endothelial dysfunction and systemic inflammation, which creates a procoagulant environment. So what you really get is a reset of homeostasis where there isn't necessarily a coagulopathy present. Albumin, as mentioned, is included routinely in LFTs and is another measure of synthetic function in the liver. It's only produced by hepatocytes and has lots of important functions in the body. Interestingly, the half-life is 20 days, so what we're getting by looking at the albumin is a snapshot of what's been going on over the past 3 weeks or so in the body, which can be quite clinically useful. Now, the reason that albumin isn't a perfect test for looking at liver synthetic function is that many disease states can reduce albumin. So a low albumin doesn't necessarily mean reduced liver synthetic function. Bilirubin is another important blood test included as standard in your LFTs. It's important to note that the value you get will be total bilirubin, whereas in actual fact bilirubin exists in two main forms in the blood, unconjugated and conjugated, the levels of which can reflect different pathologies. So unconjugated bilirubin is produced in the metabolism of myoglobin and hemoglobin. It then binds to albumin in the blood and is taken to hepatocytes, where it is conjugated to glucuronic acid, which makes the molecule more soluble. This is then actively secreted into the biliary system, where it drains into the gut and is acted upon by the gut microflora to produce urobilinogen, which is then reabsorbed and finally excreted by the kidney. So raised conjugated bilirubin therefore represents that the bilirubin has passed through a hepatocyte, been secreted into the biliary tree, but for whatever reason has been unable to enter the gut. This can be caused by macroscopic obstruction by something like a gallstone or a pancreatic tumour, or by microscopic disruption to the liver parenchymal architecture by something like fibrosis, which leads to disruption of the microscopic intrahepatic biliary duct. An isolated raised unconjugated bilirubin should make you think of hemolysis or Gilbert syndrome, which is a genetic disorder of bilirubin conjugation that has no real pathological implications. However, liver disease can also increase your unconjugated bilirubin fraction. However, an isolated unconjugated raised bilirubin will not be caused by liver disease. You will also see an increase in the conjugated bilirubin fraction as well. We also see a thrombocytopenia in liver disease for three main reasons. One, due to decreased production. This is because the liver produces thrombopoietin, which is the growth factor for platelet production, and so synthetic failure in the liver can reduce levels of this in the blood, but also because a lot of the disease processes that cause liver disease can also cause bone marrow suppression. The second reason is with liver cirrhosis, we see portal hypertension and splenomegaly, which leads to pooling of platelets in the spleen. Third is platelet destruction. As we've discussed, you get alterations of the parenchymal architecture in the liver due to fibrosis, and this alters the structure of the capillaries and increases shear stress on platelets as they pass through them. Finally, we come to some of the more esoteric disease, but which you might see in clinical practice, and therefore it's important to be able to interpret them in the context of liver disease. So we see low globulins in cirrhosis, partly due to reduced clearance of immunoglobulins by the liver, but also potentially because hepatic necrosis involves exposure of the immune system to novel epitopes against which immune tolerance wasn't generated. We can also see a hypoglycemia in liver disease, partly due to the fact that these patients are often malnourished, but also due to depleted glycogen stores in the damaged liver and reduced ability of the damaged liver to undergo gluconeogenesis. Insulin-like growth factor 1 is something that's not routinely tested but can be low in cirrhosis due to the fact that it's produced by the liver. Interestingly, this was initially thought to be a bit of a bystander process where you would see a low IGF-1 because it's not being produced by the cirrhotic liver. However, some studies have suggested that actually IGF-1 deficiency might contribute to the cirrhotic pathogenesis. Another thing that's not written here but worth mentioning is you can see a hypocholesterolemia, so a low cholesterol in liver failure because the liver is the main site of cholesterol production. Here are my references, and thank you very much for listening.